Welcome to another Preciska tumor board. We've got a great number of cases to discuss today, a lot of interesting and challenging cases. Before we get started, I would just like to go around the chat room here and introduce anyone. I'm Ben Levy. I'm a thoracic medical oncologist from Johns Hopkins School of Medicine, and I'm joined today by a wonderful faculty, multidisciplinary faculty. I'll start with Dr. Kamage. Dr. Kamage.
Hi, I'm Ross Kamage. I'm a medical oncologist. I'm the director of thoracic oncology at the University of Colorado.
Great. Dr. Ginsberg.
Hi, I'm Michelle Ginsberg. I'm director of cardiothoracic imaging and the vice chair for education at Memorial Sloan Kettering Cancer Center, and also professor of radiology at Weill Cornell Medical College.
Great. Dr. Force.
Hi, I'm Seth Force. I'm the chief of thoracic surgery at Emory University Hospital in Atlanta, Georgia.
And last but not least, Dr. Curran.
Hi, Wally Curran. I'm the Chief Medical Officer globally for Genesis Care and adjunct professor at Emory University.
Great. Welcome, everyone. Pleasure to have you all here. This is a little bit of a long and winding case here, so bear with me. This is a 70-year-old female with recurrent adenocarcinoma after receiving a right pneumectomy, hemithorax radiation, as well as several courses of stereotactic body radiation, or SBRT. Patient is positive for an EGFR mutation, at least on the surgical specimen, and somewhere along the course, we're going to learn that there's MET amplification identified in plasma. We'll go through the course, which is, again, fairly convoluted. The patient is currently on osimertinib, and the question is this a candidate for radiation therapy, or does she need to begin systemic therapy, a new regimen? So this patient presented with shortness of breath at baseline and a chronic cough. Her ECOG performance status is 2. Her past medical history is consistent with COPD and depression. Her social history, she's a no tobacco, alcohol, or drug use. Family history, no lung cancer history or other cancer history. So here we go. So in January 2007, she gets a right lower lobectomy for a 2-centimeter adenocarcinoma, and there is a positive hilar nodal disease. Based on that, it looks like she gets a course of adjuvant chemotherapy. I don't think it's over the year, but I think she gets it, and this leads up to February 2008. So far, right lower lobectomy, 2-centimeter with positive hilar nodes, receiving adjuvant chemotherapy. Fast forward 1 year, February 2008, she gets a right upper lobe lobectomy for a 2-centimeter adenocarcinoma of the right upper lobe. Fast forward to 2009, 1 year later, she gets a completion right pneumectomy for additional nodules identified in the right middle lobe. And it seems like on that completion right pneumectomy, she has pleural involvement, and at that time is tested for an EGFR mutation. Based on this, not the EGFR mutation, but based on the pleural involvement, she does get a referral to radiation oncology, and there is the completion of hemithoracic radiation, 50 gray and 29 fractions. So perhaps not, I'd like to get the input of the radiation oncologist, but we'll get through the case and then loop back around. So that's one question I want to ask as we go through this. Okay, so that's 2000 and actually, let me just stop there. Dr. Curran, your thoughts on whether radiation should be given in a setting like this post completion of right pneumectomy?
Yeah, we don't have all the pathologic details, Dr. Levy, but I can't think of a reason for hemithoracic radiation here. That's a approach we take selectively for mesothelioma patients, but even in the presence of pleural involvement, this is not going to be pan-pleura. I didn't hear anything about an extrapleural pneumonectomy. I think focal pleural involvement doesn't buy a patient hemithoracic radiation, so I don't quite understand that approach, but again, I don't have all the details.
Yeah. Okay. So far, 2 lobectomies, a pneumonectomy, and hemithoracic radiation. That leads us up to 2009. Fast forward 5 years, it seems like there's activity in the left lung now. So in January 2014, she receives SBRT to a left lung nodule, 48 gray and 4 fractions. 5 months later, receives SBRT to a second lung nodule, 48 gray and 4 fractions. There's a Guardant done in January 2015, which is roughly 6 months after her last SBRT, that reveals MET amplification. It doesn't say anything about the EGFR mutation, which we know was harbored on the original pathological specimen from her surgery. She starts crizotinib in February 2015. And then in 2018, I assume she's on crizotinib for 3 years. But in 2018, 3 years after the crizotinib is started, the PET-CT reveals new left lung nodules, and the decision is made to start osimertinib, I assume, based on the original pathological specimen showing an EGFR mutation. We don't know what the EGFR mutation is. We'll make the assumption that it's a sensitizing mutation. So the PET scan that was done, pardon me, let me just go back 1 second. So she's on osimertinib from 2018 up until now. So roughly 2 years and change, but now she has this PET scan. Dr. Ginsberg?
We have very limited images from this PET scan when you could see that there's been a right pneumectomy and there's entirely cardiomediastinal shift to the right side. And the arrows pointing to an FDG avid lymph node in the precarinal region. And we also see a small left pleural effusion, which does not look FDG avid on these images. We don't have any lung parenchymal windows to demonstrate any of the radiation changes that were mentioned on the left.
Okay, thanks, Dr. Ginsberg. So very interesting case and an interesting course here. So in terms of reviewing her radiation, again, she got hemithoracic radiation post-pneumonectomy. She's had 2 SBRTs to the contralateral lung. Given what you're seeing here, Dr. Curran, is there an additional role for radiation now that she's been placed on a targeted therapy for 2 years with osimertinib, and there appears to be disease progression in what you're seeing here on the PET scan? Is there a role for radiation? And if so, what?
Yeah, so, the prior SBRT, which seemed like both effective and appropriate therapy, would not be a contraindication. I just would need to understand, was hemithoracic radiation truly hemithoracic, and would need to review those films. If we're really dealing with a situation where the only active PET avid disease is the area we saw in that single slice, then this woman has had just a remarkable natural history of disease. And now that there's a systemic therapy, targeted therapy showing activity, using SBRT to assist that is reasonable. I just would need a lot more technical information before I comment.
Is there a role, given how much radiation she's received there on the right with the hemithoracic radiation post-pneumonectomy, I know you don't have all the data. Is this, if this were just a recurrence, that what we're seeing in that area and she was having pain, is there a role for reirradiation with protons? Does protons ever play a role in cases like this?
Yeah, I think protons is a reasonable candidate. A lot of the issue, Dr. Levy, is not so much the dose received as what is the dose to critical structures we're worried about. I think when you look at this area, the things you're worried about are airway and blood vessel. It's not spine, it's probably not even normal lung. So if you can configure a beam with either an SBRT approach or a proton approach, which gives you doses to the large vessels and the bronchus that are reasonable, I think in this case, which is an extraordinary case, it's worth considering.
Dr. Kamage, it is, I think you can agree, a interesting management in terms of the treatments received. The EGFR mutation was discovered on the pathological specimen from the pneumonectomy, or one of the lobectomies. The Guardant reveals a MET amplification. The patient gets a year or 2 of crizotinib, and then is switched to osimertinib and seems to get 2 years out of osimertinib, roughly, and now has a PET scan showing disease progression here. Assuming that maybe the patient's not a candidate for radiation, or is, your thoughts on what you would give this patient And what if there's any other tests you would do before deciding on a new regimen?
I mean, this is sort of the classic second opinion that sort of arrives in your office with a shoebox full of sort of random facts that you have to sort of unpack. So there's a lot of assumptions here. There's an assumption that all of these different events which are growing are the same process as opposed to, you know, second primaries. One would like to know that. There's an assumption that some of this targeted therapy in the past may have done something. However, if we use the crizotinib as an example, I'm highly suspicious that that's a complete red herring, because as you pointed out, if it was in the blood and they didn't see the original EGFR mutation, that didn't quite tie up. And her 2 years on the crizotinib was after the index lesion had been irradiated, so you could be misled that the crizotinib has brought anything. Which kind of brings us to the EGFR mutation. Again, you brought out exactly which EGFR mutation. Our definitive test was putting her on the osimertinib. And sure, we have 2 years without anything happening, but it would be nice to know if some of those lesions actually responded, as opposed to this just being some kind of indolent disease. So I would want to unpack all of that. And then finally, I don't know if you touched on it, but this PET avidity in the pre-tracheal lymph node, can that be biopsied? Do we actually know that that's cancer? So I would want a lot more information in terms of, you know, what is actually going on, evidence that she actually responded to the targeted therapy unequivocally before I said, okay, boom, you need to go onto this.
Let's say that, or mix it up a little bit. Let's say you did have evidence that she responded to the targeted therapy. And let's say that we're seeing definitive progression here in the nodes and in other places. Let's say radiation is considered, but she's not having a lot of pain. And you and Dr. Curran talk about it. And you say, you know what, I want to get moving on systemic treatment. What do you, off of a clinical trial, usually default to for these patients? Again, you don't have the patient in front of you. There's a lot, as you mentioned appropriately, that to unpack from here and information to collect. But given what you have, what would be considerations for chemotherapy?
Okay, so let's define our assumptions here. So let's assume that she does have an activating EGFR mutation. Let's assume that we're confident that that's what's driving what's going on because she responded to the osimertinib, and now we appear to have acquired resistance. I think in this situation, the first question is, what is her mechanism of acquired resistance, and can we deduce that from a tissue-based biopsy? So she'd need some kind of bronchoscopic evaluation unless we went to Dr. Force for a mediastinoscopy. Or maybe we could find it in the blood, although my worry is her total burden of progressing disease is so small, a blood-based biopsy wouldn't pick it up. So my first question is, can I figure out her mechanism of acquired resistance? And we know that the spectrum of mechanisms post-osimertinib is very broad. Essentially, all the rules we learned about driver oncogenes being separate get broken, and we have now seen evidence that MET amplification, RET rearrangements, ALK rearrangements, KRAS mutations, BRAF mutations, anything you can think of can come in as a second driver. So I would try and find that and see if there's a rational combination I could create. Let's imagine I can't, then it's probably a case of going on to cytotoxic chemotherapy. And there the debate is, do I keep the osimertinib going and add in the chemotherapy, such as carboplatin and pemetrexed? Do I buy into the idea that somehow I have to include immunotherapy in this, in which case it doesn't combine very well with the osimertinib, and therefore, you know, one would tend to stop the osimertinib? I'll tell you what I do. I actually keep the osimertinib going and I add in carboplatin and pemetrexed.
Is there a role for bevacizumab in that case?
It's a great question. So we do know that there is some interplay between the EGFR and the VEGFR pathways. I think in theory, you could say adding in bevacizumab might bring something, but there is no data one way or another to actually support that.
Okay, very well summarized. So if I could just summarize the kind of recommendations or the recommendations from the group, it seems like there is a potential for radiation to this area. You would need, Dr. Curran would need a lot more records. But if there's PET avid disease, maybe a consideration for SBRT, maybe a consideration for Proton, as long as it could be given safely to large structures and the critical structures. In the absence of that, or even with radiation, it sounds like if we did confirm that this was an EGFR mutation, and we did confirm there was a response to osimertinib initially, that off of a clinical trial, first of all, identifying mechanisms of resistance is critical. We have too many new therapies that may be leveraged in this case, but off of that effort, the recommendation would be to continue the osimertinib and add in carboplatin and pemetrexed.